Okay, so welcome. My name is Dr. Lauren Snedeker, and I'm the director of the Aging and Health Certificate Program at the School of Social Work here at Rutgers. And it is my pleasure to introduce you all to Dr. Rebecca Boswell. Dr. Boswell is a psychologist, supervisor, interim director of the Princeton Center for Eating Disorders. They are also the interim administrative director for psychiatric services, part of Penn Medicine and Princeton Medical Center. Dr. Boswell is welcome to share a little bit more about their background and also take us away on this journey in learning more about eating disorders and aging. We will be monitoring the chat, so if questions come up, I will hold them. And I think Dr. Boswell probably will have a bit of time for a little bit of Q&A. Although, Dr. Boswell, if you like taking them questions that is throughout, do whatever is comfortable for you.
Cheryl, thank you for that nice introduction. I am so thrilled to be here with you all today. I am Dr. Boswell. I am a clinical psychologist and have done most of my training in eating disorders work. So for me, eating disorders are sort of like the daily of what I do. But for a lot of people, eating disorders can feel like niche conditions, which is part of why I'm so glad to be here talking with you all about eating disorders and aging. And I'll just start by saying that eating disorders sometimes feel like shadow conditions, right? They're things that we know exist, but we don't really know what they're like. And they really grow in the shadows too. It can be fueled by isolation and disconnection. And with all the stressors the world has been facing, especially over the past couple of years, we've a really significant increase in eating disorder symptoms at all levels of care everywhere, and are growing in our ability to detect them, even though they lurk in the shadows. I'll just show you some quick data from COVID. So this is pediatric hospital admission. Oh, sorry, I'll go back. Pediatric hospital admissions. So you can see April 2020 hits and it skyrockets. And honestly, it has not stopped skyrocketing since then. There's so much acuity in emergency rooms and hospitals, and outpatient practices are packed. That's also true for adult patients. And so this is showing, March 2020 hits, and then you can see that compared to the other 4 years, this massive increase in the number of admissions going to hospital-based care. So, really, truly, it's been a rapid increase in the severity and frequency of eating disorders since 2020. So much so that people really talk about a crisis in eating disorder care. Part of that is because there really aren't binding standards of care. There's really a shortage of trained clinicians that have eating disorder expertise. There's really poor insurance coverage and long wait lists. And there aren't really many academic programs that have eating disorder specialized training. And so it really limits our ability to provide, specialized care, which makes me especially happy to be able to talk about eating disorder treatment with you all. And so some things that I'm going to talk about today are sort of the 101 of eating disorders. What are they? What causes them? What does treatment typically look like? And I'll focus on adults. And then I'll talk a little bit about aging and eating disorders and developmental consideration for middle and older adults and what that can look like, especially in a chronic course of eating disorders. And really feel free to interrupt me if you have questions, but I'll save time later on. But I will jump into our introduction to eating disorders. What are they? They are psychiatric conditions that often affect teenagers and young people, but also children and adults of all genders, ethnic backgrounds, cultures, body weights. And I think there's, sort of a stereotype about eating disorders. They call it the swag stereotype. So the single white affluent girl stereotype of that, those are the people that are affected by eating disorders. But that is not accurate at all. They really are very diverse conditions. There's a lot of frequency of eating disorders in marginalized and multiply marginalized populations. They just get less access to treatment, which is a real bummer for everyone involved. Common symptoms of eating disorders include behavior changes, so things like fasting, restricting, binge eating, purging, body dissatisfaction, low self-esteem, a strong desire to lose weight or an intense fear of weight gain, social isolation, and a denial of the severity of the problem. There are categorical definitions for eating disorders. They're not like super meaningful a lot of the time, but some of those categories include anorexia nervosa, which is a refusal to maintain a minimally normal body weight. Um, Anorexia has the highest mortality rate of any psychiatric condition. It is extremely deadly. People don't always realize it, but there are massive medical complications that come from this eating disorder and from any eating disorder. Bulimia nervosa is characterized by binge eating followed by compensatory behaviors. Binge eating disorder characterized by episodes of binge eating. I'll explain what all these behaviors are. And then ARFID is characterized by a lack of interest or avoidance of food, often related to sensory characteristics or aversive consequences of eating. And really, people with eating disorders can tend to migrate in between these categorical definitions based on their behaviors. And so that's why I don't think the categories really matter so much. The treatment is often the same, regardless of which category people are in, because all eating disorders include a variety of different kinds of behaviors that we would target. So one of those characteristic behaviors is restrictive eating. That's really, the amount of dietary restraint that someone is engaging in. So how tightly food intake is controlled in order to manage weight. One way that we assess that is through something called the Eating Disorder Examination Questionnaire, or the EDE. So those questions would include things like, have you been deliberately trying to limit the amount of food you eat to influence or shape your weight? Whether or not you succeeded. Or have you tried to follow definite rules about your eating, like the calorie limit, in order to influence your shape or your weight, whether or not you succeeded? And like with, all assessment of behaviors, there's sort of a continuum of the severity. But, if, as you can see from these questions, any kind of dieting behavior would be a characteristic of dietary restraint and could be restrictive eating in a pathological way. And really that's present again across all different eating disorders, including bulimia and binge eating disorder. So what is binge eating? This can be present in anorexia, bulimia, binge eating disorder. It also can be present in ARFID because it can be secondary to malnutrition. Binge eating is defined as eating an unusually a large amount of food in a short period of time with a loss of control feeling. And it's often associated with 3 or more of these things. So eating faster than usual, eating until you feel uncomfortably full, eating a large amount of food when you're not physically hungry, eating alone because you feel embarrassed, feeling gross, upset, or shameful after. But this definition of binge eating is also kind of arbitrary. So it's hard to say what a large amount of food is or what a feeling of loss of control is. Really, there's no like definition or way to gauge that, but the rule of thumb is that an unusually large amount of food is dependent on the context and dependent on some sort of heuristics, right? So if it's like the size of 2 dinner meals, that would be like an unusually large amount of food. But for example, if you ordered takeout from a Chinese restaurant and ate the whole container, even though it's like 4 servings, that's like a single thing that people eat. So that's like a normal thing to do. If everyone else is ordering a whole pizza for dinner, because it's like everyone's been excited for pizza night and that it's something that everyone eats, that wouldn't be an unusually large amount of food. Thanksgiving wouldn't really be unusually large because of the context. But for example, if someone, starts to, eat 1 slice of pizza with like something else and that's going to be their dinner, and then try to stop but can't, and eat the whole thing of pizza, that could theoretically be an unusually large amount of food, depending on the context, right? More important than like what is a large amount of food is loss of control. That's really the part that's related to psychopathology. So the ways that we can assess that is often through metaphor of that feeling of loss of control. And so sometimes I'll describe, you're at the top of the hill, you have a ball, you're rolling it down the hill, and it starts rolling faster and faster and faster, and there's no way you're going to catch it. That's that loss of control feeling. Or it can be kind of like you're kicking a can or a rock down the road and you like run to go catch up at it, but it's rolling too fast. You can't get it. Or like you're at the train station, the train's already left. There's no way you're going to get on that train. That feeling of like wanting to stop something, but not being able to is sort of that loss of control feeling. If someone eats a large amount of food and they feel fine about it, it wouldn't be a binge episode. So like last night when I had Chinese takeout and I ate the whole thing, I don't feel bad about that at all. So I didn't binge. I just overate. What is purging? Uh, it's sometimes called purging, sometimes called compensatory behaviors. They can really be lots of different things. It could be vomiting, laxative use, fasting, over-the-counter or diet pill use, or even driven exercise. And whether it's compensatory behavior can depend on, again, the context, whether it's excessive, whether it's intended to counteract a binge or be part of a restrictive practice. And I will just note that, vomiting is not actually an effective way to get rid of like food that's been consumed. So even after purging through vomiting, a body absorbs 40 to 75% of calories that are consumed. And typically when you tell folks that are engaging in vomiting, this is something that helps them stop. I'll also say that laxatives don't at all change the amount of food consumed, like absorbed. So they don't really do anything in terms of weight control. They just make people dehydrated, which then feels like it's changing the body, but it's not really. And I will say that both of those behaviors do have some danger associated with them. I'll go through that in just a little bit. But when people vomit frequently, that can cause damage to their esophagus, to their teeth, to their gums. It can also cause electrolyte imbalances that can put them at risk for sudden cardiac events, and even death. And long-term laxative abuse can permanently change the GI system and mean that people are needing to take medications to have regular GI function throughout the rest of their lives. So it's serious. Okay, so I'll tell you a bit about some of the cognitive components of eating disorders. It can vary person to person, but some of them can include preoccupied thoughts about food or body weight. Sometimes people have obsessive compulsive tendencies around food, including ritualistic behaviors at meals and collecting recipes or preparing meals for other people, spending a lot of time planning or preparing or getting ready for food intake. Some people have magical beliefs about food, so it could be something as like atypical as, green foods are safe and brown foods are unsafe. Or if I eat a cookie, I'll gain 20 pounds. Factually incorrect, but something that people can really believe. Avoidance or rituals surrounding weight or shape. So wearing really baggy clothes, not looking in mirrors, or doing some rituals around those things. People also can experience overvaluation of shape or weight. So if you think about a person and all the things that define them, like student, like social worker, family member, athlete, whatever those things are. And people with eating disorders, a lot of times you see that their body or their shape or their weight take over how they see themselves. Those other things matter so much less than they used to because their perception of themselves is so tied to their appearance that becomes the most important thing. And part of treatment is really helping people diversify that self-concept and think about themselves in other ways. I'll go through like a brief interlude about medical concerns with eating disorders, and I feel obligated to talk about this in part because I work in the hospital, and so see these things happen all the time, and it is horrifying. And I don't think that, um, you know, it's a scary thing to see eating disorders when you don't have the support of medical professionals or at least have medical evaluation. Um, so eating disorders can have serious complications with every single organ system in the body. People sometimes get eating disorders detected when they're dizzy or when they faint. And people think like, oh, it's no big deal. Like people faint every once in a while. But ultimately that's reflecting cardiac problems and underlying like significant cardiac risk. People who engage in vomiting behavior could have dental erosion and cavities, like I mentioned. There's all other kinds of cardiovascular complications that can happen. So sometimes heart palpitations, arrhythmias, bradycardia, so like a very low heart rate, hypotension, very low blood pressure, or edema, which is fluid swelling. And edema is really reflective of early stages of heart failure. And so all of these things indicate that there's a lot of stress on the cardiovascular system, and can be fatal. People also have GI complications, so they might talk about bloating or nausea or GERD or constipation. People with eating disorders can also experience gastroparesis, which is delayed stomach emptying. Basically, when there's food restriction or malnutrition, the GI system gets deconditioned. It's not used to sending food through all the different intestines and things. And so food stays in the stomach longer and stays in the intestines longer, which can cause a lot of bloating and nausea, but can also itself be a real complication. It causes a lot of discomfort. And a lot of times there's no way to get over that unless you go through it. And so people, when they're practicing nourishing themselves again, they have to recondition their GI system over time, which is really painful a lot of the time, but it's just part of the process. People can also experience, if they're assigned to female at birth, might experience amenorrhea. They can also experience bone fractures or osteoporosis. And so the osteoporosis and bone-related complications are when the body is trying to get nutrients that it's not getting through a food intake. And so it leaches all the calcium from your bones to be able to maintain standard functions because calcium is so important. And unfortunately, there's no way to gain that bone density back. So this is one of those things that is irreversible. And so once the calcium's gone, it's gone. You can take calcium supplements, but you won't regrow bone. And so it is wild to see like 10-year-olds with the bones of 70-year-olds, or to see people in their 40s who are way less mobile than they should be because of all of the bone-related complications that they've had due to malnourishment. Cognitive components. So people can have a lot of poor concentration, a lot of difficulty sleeping, or even seizures. The seizures can be related to electrolyte imbalances or just, malnutrition effects. People lose their hair when they're malnourished. Lanugo is like a very fine body hair that grows as a way to help regulate temperature when the body's sort of slowing down because of malnutrition. And it becomes like too costly metabolically to keep your temperature up. The hair will grow instead to try and keep you warm. Poor wound healing, right? So again, if the body's in like the starvation mode, it's like only doing the most important things like keeping your heart beating as much as it can. And so if you get a cut on your finger, it's not healing for 2-3 months unless the priorities shift in the body. So really major, right? And these are just some of those complications. And these medical complications can happen in someone at any body size with any eating disorder, right? So you can't tell just by looking at someone how sick they are or how medically complicated their case is. So, when providers have weight bias, when we judge that, people in larger bodies would be at less risk, they often can get even sicker than people that visibly look like they have, a restrictive eating disorder because they're in a very small body. And so, that's also part of the importance of assessment, that we're really considering that anyone can be malnourished and can be at really significant risk. And because this malnutrition can impair cognitive functioning, sometimes we have to take over and help people become fed so that their bodies and their brains are appropriately nourished. One of the ways that we learned about this was through the Minnesota starvation experiment. So this was a study in the 40s with conscientious objectors in World War II, led by Dr. Ansel Keys. And he recruited a group of healthy men with no eating concerns, no mental health concerns, and put them on a semi-starvation diet to figure out what happens when people are malnourished and figure out how to refeed them in a safe way. So there were famines around that time, and we didn't really know how to get people healthy after famine. And so that was part of this. So this is what the men look like before and after. There was 35 men who agreed to starve so that, people who were suffering from famine could be better fed. He put them on a semi-starvation diet, which for them was about 50% of their caloric needs, around 1,800 calories, which, by the way, is significantly more calories than a lot of weight-related or weight loss programs would recommend. So just want to be clear that things like Noom and Weight Watchers are recommending severe semi-starvation diets for most people. What was noticed in this was not only the bodily changes that you can visibly see here that medically they were assessed, but also a lot of cognitive changes. And so people had difficulty concentrating. They started to obsess about food and calories, became depressed and anxious, even though they had no history of that, would engage in binge eating, would hoard food, felt very fatigued, even felt suicidal at times. Um, and these were things that happened only because of the malnutrition they experienced, not because of any predisposing factors or other stressors. So that really shows that our brains and our bodies have a starvation mode that gets activated with malnutrition, where we focus more on food because we need to survive. And sort of feeling good is a secondary bodily function. It's, less important than keeping your heart beating. And so, if there are, physical resources that have to be distributed, it'll go into keeping bodies safe and surviving instead of into like cognitive and mental wellness. What they also learned from this study is that there are some dangers around going from a starvation state to a refeeding state. And so that's where we learned about something called refeeding syndrome, which can be very dangerous. And so when you're working with patients who might have been really severely restricting their food intake, especially for a long period of time, it's often a lot safer for them to start eating more under medical supervision or in the hospital. There are some severity indicators to think about. So body mass index, very low or very high BMI, can be, some severity indicators. Those are the BMIs where there are health risks associated with all-cause mortality. And so when people are, at very low BMIs, they're at as much, if not greater risk than people at higher BMIs. For kids, this is often defined by, did they fall off of their growth chart in their development? For adults, that's something that we don't necessarily have data on, but we do our best. When the eating disorder feels like this is just who I am, that's a severity indicator. It's concerning. It's a difficult process to disentangle that, but it still happens. Age can be a severity indicator, both onset at a very young age and persistent illness at an older age. Things like frequency of binging and purging can also be severity indicators. But really we need to, when thinking about severity, look at a full physical assessment to figure out where there is risk. And that often determines whether inpatient or outpatient treatment is indicated. All right, so that was our brief eating disorder overview. I'm going to shift into talking about what causes eating disorders. And really the answer is that we don't know. It's a complicated condition. Taking a biopsychosocial model into consideration, there's many predisposing risk factors, both biological, psychological, and social, that could lead to an eating disorder. Or we don't have one specific cause, like we don't for many mental illnesses. CBT models of anorexia often, point to this like cognitive cycle, a cognitive behavioral cycle that people get stuck in. So if we start with this, trigger of a precipitating event, whether that's noticing your friends are dieting or someone passes away or some major stressor happens, predisposing things like, for example, perfectionism might create a need for control and overvaluation of eating and weight and shape that would come together around a need to diet. And that would feel, in this model, good in the short term, but not so good in the long term. And that it would intensify restriction, lead to effects of low weight and avoidance of other feelings, and then become, a cycle that people get trapped in where they don't actually feel in control anymore. And that's, the CBT model where we would intervene in multiple places. Developmentally, I'll just say that body concerns often start early. And these are old data. It has honestly only gotten worse. In the 90s, 42% of first and third grade girls wanted to be thinner. 81% of 10-year-olds were said that they were afraid of being fat. Half of teenage girls and a third of teenage boys were using maladaptive weight control behaviors. So, really early onset of these body image concerns that are thought to be precipitants of eating disorders. If we look at, age of onset, for the most part, onset happens in earlier years. So in that like pre-adolescence, adolescence time, although there's a sizable portion of people who have later onset eating disorders. It can vary by condition, and so anorexia and bulimia tend to have earlier ages of onset, whereas binge eating disorder might onset at multiple parts of the lifespan, including in middle age. And so there seem to be, those two distributions of folks with binge eating disorder. So that's more common to have a later in life onset. Okay, so treatment for eating disorders. I will share the treatment recommendations for adults. They can vary by diagnosis, and so these are just, the ones that are gold star evidence-based. There's more treatments being developed, but really broadly what we see is that CBT tends to be the first line treatment. There is a CBT protocol for ARFID that's very good. And then second line treatments tend to be more interpersonally focused across conditions. When CBT is available, it is very good. And so this is showing that CBT is much better than inactive treatments. And so both therapist-led and self-help versions of CBT are effective for eating disorders across different conditions. And it's much more related to improved quality of life and subjective well-being when we look at CBT compared to other treatments. CBT has several stages of treatment for eating disorders, and so stages 1 and 2 really focus on engaging people in change and managing resistance or ambivalence about change, and working on regular feeding and eating, as well as measuring weight every session as one of those vital signs. And depending on where someone's body is, the way that eating happens or the pace at which weight is restored can vary. At stage 3 and 4, people start to work on changing dietary rules, challenging fear foods, challenging distorted thoughts about weight, body, and behaviors, building up body satisfaction and self-esteem, and addressing other stuff like interpersonal problems in life, as well as teaching coping and relapse prevention strategies. In terms of behavioral components of treatment, regular eating is the bread and butter of CBT for eating disorders. It's important to have regularly timed eating. So for example, we often recommend 3 meals and 3 snacks that meet someone's nutritional needs. And people can self-monitor that when it's appropriate, depending on the stage of their illness. We also have a lot of exposure components in CBT for eating disorders, so that can include measuring weight itself as an exposure, as well as working with feared foods and body image concerns. There's a very good free app called Recovery Record that logs mealtime and looks at, precipitants of restriction or other kinds of behaviors. So it looks at, different kinds of feelings people might experience, and then, secondarily is interested in what people were eating so we can help them meet their nutritional needs. And this is, a patient-led app where the clinician has access to it. And so I would recommend that for CBT for eating disorders. In terms of exposure exercises, those are really paced later in treatment, but can often be around feared foods, around weight, or around body image and shape. So distorted body image is often a symptom, and so helping people realize that misperception can be helpful. And as can focusing on body function versus its form. So, what your body does for you. It's basically your ticket to experience life. So you've only got one body. How do you use it in an effective way is sort of the rationale for that. I will say that there's like mixed opinions about exposure exercises for body image, especially in people in larger bodies or who are gender diverse, that it can cause a lot of distress if people are not appropriately prepped for that. And so being really thoughtful about how and when these exercises happen can be really important. And for people in larger bodies, really understanding that they do face a lot of weight-based discrimination in their lives. And so being in that body can be really difficult. And so not forcing exposure in ways that feel harmful to them. But yes, this is showing mirror exposure, sort of someone might see themselves as much larger than they are, sort of correcting that misperception. But if someone actually is in a larger body, coming to some acceptance of that when they feel ready. And then feared foods, people really do feel like a cupcake's going to eat them in their sleep, and it's not, it's just a cupcake. Um, Cognitive components. So with all CBT, there's thought records where people identify distorted thoughts and core beliefs related to the eating disorder, as well as coping skills. So working on tolerating distress, regulating emotions, etc. And that can be a really useful tool. Some examples of distorted thoughts and eating disorders include black or white thinking, like this is a good food, that's a bad food. I can eat this pizza, or I can eat none of it. Emotional reasoning, like I feel fat, so I am fat. We often say that fat is not a feeling. And so what's the actual feeling behind that experience? Shoulds, like I should be thinner. Personalization, like I'm a bad person if I can't adhere to my eating plan. And like with all CBT-based interventions, there's some core beliefs that are common in eating disorders. Those include defectiveness, emotional deprivation, emotional inhibition, enmeshment, failure to achieve, thoughts about self-control and discipline, social isolation, really high standards and over control. And so a standard CBT model would apply to eating disorders in the same way that it would for anxiety disorders. It would just include really close monitoring around behaviors first to keep people safe in their bodies. Okay, so I'm going to shift to talking about aging and eating disorders, in part by talking about eating disorder remission over time. So this is data from a longitudinal follow-up evaluation of eating disorders. This is when people are diagnosed and then their probability of non-recovery. And so people with anorexia and bulimia are likely to recover increasingly over time. Likelihood of recovery improves. But what we see is that there's still a group of people that are not recovered, even 12 years later. And so although onset is typically earlier in age, people can continue to have eating disorders for a long period of time. So at some point, the question starts to become what kind of, oh yeah, this is at 22 years. So 2/3 of people in this case, females with anorexia and bulimia were recovered, but there's still a third that are unrecovered. And then that question is the question of like, well, how are we defining recovery? So the definition of recovery in that data is a psychiatric status rating of less than 2 for 52 weeks. So it's focusing on symptoms. What that means is that 1 is no symptoms at all. 2 is that they're 95% of their target weight, which is, based on where their body naturally should be, with some body image disturbance, fat phobia, or overvaluation present. But there is, lots of other numbers here where people might be almost there, but missing the mark a little bit. And for lots of people who have longstanding eating disorders, this is way more than they're asking for. They don't necessarily want to ever be 90% of their target weight. They might not ever be able to let go of body image disturbance. And so, are there ways to think about this in a more nuanced way? And what about treatment for those people that are non-responders, right? Who continue to have their eating disorders into their 30s, 40s, 50s, and beyond. And that sort of led to some research on what is being called severe and enduring anorexia. It is not a categorical definition of an eating disorder. It's just a research idea. But the idea broadly is that 20 to 25% of people with anorexia might experience a chronic form of the illness. And most definitions of this tend to include living with anorexia for a long period of time, having a history of multiple treatment interventions that have not resulted in sustained recovery. And that gives us the question of like, what is a long period of time? There really is no clear cutoff because it is not a real category, but some definitions require reaching adulthood. So you're 18 and over, and then having prolonged illness in adulthood, others don't. I tend to prefer this idea of wanting people to reach adulthood first before we start the timer, in part because labeling a 15-year-old that's been sick since age 10 with the idea of like a severe enduring anorexia versus adult in their 50s and 60s is very different. The average course of illness is estimated to be 2 to 5 or 5 to 7 years. And so, again, that starts to be question like whether there are different trajectories of the illness. Of the most common definition is around 7 to 10 years of having a longstanding eating disorder. And yeah, I mentioned some of those developmental concerns that like a long course of illness for like someone with an early onset is different than a long-standing illness across the course of someone's life. Other questions about this diagnosis include what is severity? So in DSM, it's often based on BMI, but this is not really like super useful, especially when people are in and out of treatment. Another question is whether it can really be treatment resistance or failure in treatment if it's accessible or inaccessible or inflexible. So for a lot of people, it's hard to find a treatment team. A lot of people are limited to public insurance, especially if they have disability status or socioeconomic barriers. And it's often hard to be put through the same protocol every single time. I will say too that we see in a lot of our older patients in like their 50s, 60s, 70s that they didn't get treatment when they were young. They started to get treatment when they were older. And so I don't know if it's really possible to say that this is, treatment resistance or failure if they're only starting treatment in their adulthood when their brains are less plastic. And if they sort of live with this illness for so long, that in part this might be a reflection of people not having access to treatment earlier in their lives. And so, we were curious about lots of things, including patient experience, right? Like what would it mean to be labeled with something like severe enduring anorexia, and how would treatment change? There are some data about like the severe enduring type category and how people do in outpatient CBT. So there was a study with 134 patients. They were younger, right? So the mean age was 22. They excluded people with medical instability and some comorbidity. It was in Australia. And they had 51% of people be treatment completers, which is like, oof, a gut punch. You really had a lot of dropout in this trial. And what they found was that there seemed to be a, a slower rate of change. So there was a greater weight change in those with severe enduring using that 7-year criteria, but they started lower and it took them longer. They might have been more experienced with the restoration process, but being in treatment longer for them was better, which is like an interesting thing with that 51% dropout. That they weren't keeping people in treatment, but the ones that stayed did pretty well. They also showed that there is some relationship between duration of illness and severity, but everyone gets better. So that's a good thing to see. And there's also no follow-up data, so we don't know how long people maintained these gains. This is another study showing outpatient CBT. So it's a CBT or like supportive clinical management approach. These were adults who were sick over 7 years. They had very low BMIs. Again, in Australia, more people completed treatment, so it's almost 90% here. And what they modified in CBT was that they set goals collaboratively. Weight change was not assumed, and motivational enhancement could continue throughout. And what they found, I'll show you a lot of numbers, but I'll explain it. What this is showing is that ultimately everyone gets better. So quality of life, depression, social adjustment, eating psychopathology, readiness for change. And that's true for CBT or the supportive clinical management process. But there are differences in magnitude of change by treatment type. So it looks like, some of the targets that are more around like quality of life changed more sometimes in supportive clinical management compared to eating disorder specific things for CBT. When we look at inpatient and PHP treatment, people were enrolled in a study. They did 13 weeks inpatient and 7 weeks in a day hospital in Italy, which is why they had all of that healthcare coverage. People do not have that kind of access in the US. They had like a weight gain goal that's consistent with inpatient level of care in the US. Use that 7-year criteria, and 84% completed treatment. And what this is showing is that people with severe enduring condition did just as well as everyone else, including in follow-up. This is the same study showing similarities in eating disorder symptomatology. There's some possible variation in symptom-related outcomes, but it's not really significantly different. So if we translate these Italian and Australian studies to a US treatment context, it's different because Medicare and Medicaid coverage for eating disorder treatment in the US is really bad. Inpatient care is often for a limited duration for Medicare participants, and residential treatment is not covered at all. There are very few, if any, partial hospitalization or IOP options. And then in outpatient care, there are really few providers, and dietitians are not covered for eating disorders for Medicare folks. Comorbidity is also more of a rule than an exception. So people can experience complex PTSD or OCD or psychosis. And that was not reflected in those clinical trials. In an aging population with this, whatever severe enduring anorexia is, they likely have long-term care needs. So might need access to assisted living, might need access to outpatient enteral feed support. So a lot of our patients with really severe eating disorders often need NG tubes, G tubes, PEG tubes, et cetera, which requires, really specialized medical providers to be able to prescribe that, and who can understand that it's different for someone with like structural feeding and eating difficulties compared to anorexia or another eating disorder. I'll just plug our protocol really quickly. So we started at the Princeton Initiative for Severe Enduring Anorexia, or PISA. This is a research protocol. I call it PISA because of the Leaning Tower of Pisa, that, the foundations shifted over time. It's sort of like, it's tilting, right? And it's never going to be straight. It's never going to be perfect, this tower, but, it's good enough. It's still standing. And this is a clinical research protocol. It's still being tested, but more or less, the goal isn't to fix the foundation. This building has withstood hundreds of years anyway. And it's really a metaphor for imperfection and resiliency, that we want people to be standing. We don't need them to perfectly recover. And so our treatment stance is really harm reduction focused. And because it's a research study, we are really agnostic about what's best. We want to collaborate and be hopeful with our patients, regardless of where they're at, and try and find a new path forward. And really, our protocol is defined more by this treatment stance than by any particular intervention, which we've been having a lot of success with anecdotally from a clinical perspective. We have different stages of treatment based on their medical severity. So in acute stages, we really try and focus on medical and nutritional safety. And then when someone has, minimal safety, then we can start to challenge precipitating and maintaining factors for an eating disorder, and start to look at triggers for relapse and access to corrective intervention. So asking those questions to help people try a different path when they leave the hospital. And really in this context, we are trying to strike a balance between acceptance and change. So real desire to provide safety for patients is in that change bucket. And we get really scared of those acute risks, especially in early stages of treatment. And want to pull people out of their eating disorder as much as we can, because we want them to be free and to live their lives. However, there are some things to accept as treatment team providers, like that people who have this version of anorexia, whatever it is, have multiple treatment experiences that haven't served them before, and that their acute risks might be better managed by a patient accepting recommendations instead of leaving against medical advice. And so we really think about collaboration as an orientation and a privilege for maintaining medical safety, and sort of want to find people their best outcome, often because developmentally, folks with this longstanding presentation are later in life, have already been to school, built a family, built a life for themselves, and we want to get them back to their life as much as we can, instead of keeping them in treatment forever. And so that's what I've prepared today. Happy to answer any questions, and hope it was an informative conversation.
Thank you so much, Dr. Boswell. That was incredibly informative. I'll pause here to see if those who were able to remain have any questions. I know I have some questions, but I want to open it up to our attendees first.
I have a question. Any pharmaceutical help? I mean, is there anything other, I mean, I know there's obesity drugs out there. I wouldn't think that would be appropriate, but what kind of medications have you seen to be helpful?
Sure. Well, I would agree with you that obesity medications are not appropriate for this population. And we really discourage that. And people that do have medical conditions like diabetes or whatever, we can like talk with their doctors to figure out a way to keep them safe medically. In terms of psychiatric medications, there are no medications that are specifically FDA approved for anorexia or bulimia, but a lot of times people will prescribe antidepressant medication. Those medications tend to not really work super well until someone is more weight restored. And so oftentimes people will prescribe olanzapine or Zyprexa, which helps both with some of those really distorted eating disorder thoughts and with weight restoration. There's like a metabolic process with that drug that helps people gain weight, which is great. And that's, I often see that used for kids and for adults. For binge eating disorder, there is one FDA approved medication. It's Vyvanse. However, you can only use it in the short term. And
That's an ADHD drug.
it sure is. Yeah. And it's comes with its own risks, right? So it comes with cardiovascular risks. It also can make restriction worse in people with binge eating disorder because they lose appetite. And so I think there's a real cost benefit to that medication. I will say the Academy for Eating Disorders is about to release pharmacological guidelines for eating disorders. And so that'll be out in the next month, and I'd be happy to forward that along.
Okay, thank you.
Sure.
Thank you. And Dr. Boswell, I think we have a question in the chat from Bethany. I'm curious if we see any connection between midlife and aging eating disorder onset with perimenopause and menopause.
That is a great question.
Yeah.
So there are some studies that link perimenopause and menopause with relapse to eating disorders. So people that had earlier onset often relapse around that time, in part because there are natural body changes that someone that's hypervigilant around their body might respond to. There's also some data on like new onset binge eating disorder around that time, related to, hormone changes and body changes, and that being like an easy source of comfort or distraction for people. So yes.
Thank you so much. Oh, and Bethany, thanks you. I'm so glad to learn about PISA and I love everything about it. How do you feel that differs from more from models in past? I can tell that it has a lot to do with maybe the acceptance of where the person is and sort of restructuring what we define as recovery. But can you elaborate a little bit more for those of us, myself selfishly included, that aren't experts in ED and disordered eating?
Totally. Well, there's historically, I mean, it's very odd in a condition that's so rigid that the treatment recommendations can be so rigid. And so a lot of our inpatient and medical stabilization protocols are like very strict around people, need to gain 3 to 5 pounds per week. They need to have this amount of nutritional variety in their diet, and here are the consequences for them if they don't, as a way to sort of corner the eating disorder and create external conditions for motivation when it's not internally motivated for people that are very sick. And for a lot of people that works and gets them out of the hospital fast. But for a lot of people, it doesn't. And so I think the sort of rationale for the PISA protocol is to say, those recommendations came from somewhere, but it certainly wasn't like fully data driven, and it works for a lot of people, but we don't know how many, and there's some that treatment's not working for. And so it tries to think about like if people, for example, respond more to like positive incentives instead of restrictions, or if people respond more to, having accommodations around variety within, some safety parameters, or if they need a slower weight restoration to prevent an increase in body image concerns. And if that keeps them in treatment longer, then maybe that's another path forward.
Thank you so much. That was so clear. And I appreciated your comparison with how you sort of like cornered the eating disorder as opposed to PISA, which is, it just seems much more exploratory, or, giving space, fluctuating with the person. And really, I think it also
Yeah.
respectfully helps examine systemic impacts very well, from what you've shared, which I think is
Yeah.
incredibly important as well in this context.
Yeah, I appreciate that. I will say that there are some data about like developmental recommendations for like timing of different intensity of intervention. So, even with our PISA protocol and testing to see how it works for people, um, I would still have a hesitation to slow things down for kids, right? Because they're in this like really significant developmental time where they're still growing, their bodies are still changing, their brains are so plastic. And there are data that the faster you get kids weight restored or back on their developmental trajectory, the better they do long term. So I think our balance around that is like fast as we can with kids. And when people have tried that for years and it hasn't found them a better path, to try and build something new and creative.
Yeah, absolutely. That makes sense. And just in our last few minutes, because we're a school of social work, and as we discussed just in our earlier connections and prior to getting onto the call today, any last points or pearls of wisdom for social work students, especially some that are already working, that are going to be working, just sort of specifically, and I'm biased because I'm a gerontological focused social worker, but particularly focused on working with older adults as we discuss sort of like how we're covering relationships to food in our biopsychospiritual assessments, which is like our bread and butter assessment kind of approach. If you have any comments based on your work and expertise for us who've been in the profession a long time or are emerging into the profession, that would be really great.
Yeah, absolutely. Well, I would say in the context of eating disorders, really having that full picture of a person, that their full biopsychosocial spiritual model is really helpful, not just for understanding all the things that contribute to someone's experience, but also in recruiting a really good team who has your back to treat their eating disorder. And so, especially with eating disorders, it's so helpful to have social work coordinating care with doctors and dietitians and other medical professionals to keep people's body, mind, spirit in healthy balance.
Thank you. Thank you so much. We've got about a minute or so left, so we'll just see if there's any other folks joining, if they have any questions. Just give it a minute. All right. Okay. Well, thank you so much, Dr. Boswell, for all of the information you've shared and for giving us some of your time and your expertise. And I'm very excited to learn more about the PISA protocol and keep us posted about how this goes. And I'm going to go ahead and stop the recording now. So thank you.